Okay, everybody, I'm going to get started. I see some names on the participant list that I might not know. So, um, hi, I'm John Hayes. I am a family and addiction medicine doctor, and I work at Columbus St. Mary's Family Health Center for a little bit. And I'm one of the founding members of the new Southside Family Medicine residency. I went to the American Society of Addiction Medicine conference like last week, 2 weeks ago now. And there was some really important information there on buprenorphine and our current drug crisis. And I feel it's just important to share it with this crowd. So thanks for coming and thanks for tuning in to learn a little bit more about buprenorphine and the opioid crisis. Nobody pays me anything other than the department. I have no disclosures. So one of the main things that I want to make sure everybody knows is that you're all buprenorphine prescribers. There's no such thing as a buprenorphine waiver anymore. Congress passed the MAT Act as part of its year-end budget update in December 2022. And as part of this, there's no bup waiver at all. So if you have a DEA license, you can prescribe buprenorphine. There's also no limits to the number of patients that you can prescribe to. Previously, it was like 30 in the first year, 100 after that. That's all gone. So this is great news. This is something that I feel like didn't really get adequate press. Biden talked about it in the State of the Union, but congrats, you're all bup. If you have a DEA license, you're a bup prescriber. Another thing I think people don't necessarily realize or hasn't gotten a ton of coverage is that the opioid or drug overdose crisis is worse than ever. 108,000 people died in the US in the last 12 months of drug overdose deaths. In the last 5 years, around 450,000 people died. So a message that I really think that we should share with our colleagues, we should also shout from the rooftops, other than there's no bup waiver anymore, is that this is everybody's problem. There is no regulatory barriers for you to prescribe buprenorphine. So if you ever see a patient on chronic opioids with problematic use, or if you ever see a patient with opioid use disorder, it is your responsibility as a primary care physician to start them on medication-assisted treatment. There's really no excuse anymore. I can't think of a legitimate excuse why you wouldn't do this work. Maybe you're not comfortable, but we're family doctors. We're not comfortable with tons of things. We learn over time. It's not that complicated. So I think we need, honestly, I'm getting a little bit more aggressive in my rhetoric here, but I think we need to call out our colleagues, other physicians that aren't doing this work and say, like, look, there's a public health crisis. There's no regulatory barriers. This is everyone's responsibility. Why aren't you doing this work? I also think this is an inspiring message for students to pull up this graph and to say, look, this is something that family physicians can do really, really well, that this is our responsibility. We can provide wraparound services and really significantly help these people. So why have we seen kind of around 2020 a spike in overdose deaths? Well, I mean, the obvious answer is fentanyl, right? We saw, interestingly, maybe partially tied to the CDC opioid guideline, a lot of people getting kicked off their prescribed oxycodone and opioids, turning to heroin, and then the heroin market turning to fentanyl. Fentanyl is a extremely potent, odorless powder that can be pressed into any form you want. So it's extremely easy to smuggle. It's basically, there's no way to stop fentanyl from entering the country. We're going to be dealing with fentanyl forever. It's an easily synthesized, easily smuggled drug. So for those of us that are treating addiction, we kind of just have to learn to live with it. And the prevalence of fentanyl in the US drug supply is one of the main reasons why I'm giving this talk. It's changing the way we need to prescribe buprenorphine. So I'm sure y'all have seen this, but fentanyl is in pretty much the whole US drug market. It's in Xanax. So these are all pictures of things that have fentanyl in them. So you see like the real Xanax bar and then the fake Xanax bar on the right there. You see two different versions of oxycodone. It's basically they're even if people think that they're taking pills, they're still taking fentanyl. It's also mixed into all forms of heroin, either accidentally or on purpose. It's mixed with cocaine now. And people sometimes ask, well, why would you do that? Well, because if you use cocaine regularly, then you get opioid dependent at the same time, and you create better customers. There's also like some evidence that the cocaine adulteration with fentanyl is an accident. It's just because, you know, you have people using blenders to mix a little bit of fentanyl into whatever their drug is. And it's not like they're chemists, right? They're not cleaning the blender, and sometimes you just accidentally get it in there. So before I talk to you about like updated buprenorphine prescribing guidelines, I wanted to say, by the way, if you have a question about anything I'm saying, like please throw it in the chat. We should have plenty of time at the end of this talk to ask and answer questions. One thing that I think everybody should be comfortable with is harm reduction messaging. I know this is a busy slide, but this is kind of what the basics of harm reduction looks like for people that use drugs. Basically, don't do drugs is an ineffective message. People are going to do drugs. They've been doing drugs throughout history, forever. So actually, I think the message is for our patients to keep them from dying. It's, well, if you're going to do drugs, you should do them safely. So do them one at a time. Most drug overdose deaths have multiple substances on board: alcohol and opioids, benzos and opioids, cocaine and opioids, stimulants and opioids. So don't mix your drug with other drugs. Another thing is you can always do more drugs. So normalizing, talking to patients that don't do the whole line all at once. Do a little bit, see how it makes you feel. The drugs are extremely potent now. And then if you need more, use more. But use a little bit first. If you're going to do drugs, do them with someone. There's a lot of people that die alone in a bathroom or a bedroom because they're ashamed of their drug use and they didn't want anybody to know about it. And a family member or a friend or even another drug user could have Narcaned them, could have saved their life, but they just won't. They were just alone. There's also a really cool resource I hope everybody knows about called neverusealone.com. So if you're using and no one else is around, what you can do is you can call a hotline anywhere in the country, give them a pseudonym, tell them where you are, and they'll talk to you while you use your heroin or fentanyl or whatever it is you're using. And if you go unresponsive, after a certain period of time, they can call EMS for you. Sure, we should give out lots of Narcan. That's kind of the bare minimum, but a motivational interviewing style question I ask people is like, hey, patient, can you Narcan yourself? And the answer is absolutely not, right? If you need to use Narcan, you're unconscious. So you have to emphasize that you really need to use drugs with friends. A lot of the drug overdose deaths are intentional. So there's like a suicide epidemic kind of mixed in with this opioid epidemic. So assessing mental health, like I'm sure you all do, is really important. And then drug testing is important. You know, interestingly, basically the entire US opioid street supply has fentanyl in it. So drug testing for opioids is kind of iffy. What drug testing has shown to do is change behavior in the patient. Because if they thought they bought heroin, they know that it has fentanyl in it, usually they're still going to use the drug. They spent their money on it. It's not like they have many other options. But if they know they have fentanyl, they'll often use less, or they'll be more careful, or they will have a friend around. And it's really important that anyone that thinks they're doing cocaine, anyone thinks they're doing Molly, any white powder, or even random pills that they think that where they think they know the substance and they didn't buy it from a pharmacy, they should test that for fentanyl, because I think a lot of that could prevent a lot of accidental overdose. And then it's pretty easy to get clean needles and clean drug supply. There's a great organization here in Milwaukee called LifePoint Needle Exchange. And if you're joining us from a more rural setting, there are needle exchanges that do like discreet free delivery everywhere across the country. All right, so I'm getting into new content. This is the last like old slide that y'all may have seen, but treatment with buprenorphine or methadone or naltrexone is the standard of care for the treatment of opioid use disorder. It drastically reduces mortality. People with an opioid use disorder die about 6 times the national average, and you cut that by 2/3 by simply just giving them on buprenorphine. That's not including all of the other stuff we do. It's not including the psychotherapy. It's just getting them on bup. But then we know as like family physicians that there's even more stuff we can do. We can treat their Hep C. We can give them birth control. We can treat their HIV. We can treat their blood pressure and give them a statin. We can do all of the things that we do naturally, get them to stop smoking. Okay, so some new content. Some of the stuff, if you see ASAM in the bottom left, I've literally stolen it from an ASAM presentation from 2 weeks ago. So when you think about buprenorphine, if you're thinking about it as a drug just for people with opioid dependence, you're kind of thinking about it wrong. We see a lot of patients in our primary care clinics that have complex, persistent opioid dependence, right? They have really intense need for their opioids. They can't control their use of the oxycodone. They're very dependent on the drugs, and they have some problematic behavior associated with it. Well, those patients are excellent candidates for buprenorphine, and I think we just have to learn how to sell it to them to get them to switch. One is bup is a really potent analgesic. The old school, the kind of myth about bup is because it's a partial mu opioid agonist, it only partially works for pain. That's not true at all. It's actually much stronger than morphine and its analgesic properties. There's no ceiling effect for the analgesia of buprenorphine, so that people used to think that because if you take bup, you have a ceiling effect on respiratory suppression, meaning you don't overdose. They used to think that, well, it must have a ceiling effect for analgesia, so more doesn't provide more pain control. That's also not true. So more bup provides more pain control. There's a really good article here at the bottom of the Gudin and Fudin pharmacological review of buprenorphine. Like if you want to check my work here, but it's accurate. So it works for pain. It also is much safer, right? It has a ceiling effect for respiratory suppression, so you're not going to overdose on this drug. And it tends to treat pain centrally or peripherally, I mean, like in the spine, and not necessarily in the brain so much. So it doesn't cause that euphoria or that sedation. It also has some anti-hyperalgesic effects, which I think is really useful Um, you know, many of us are prescribing chronic opioids to patients, and what we find is that over time, our patients are escalating in doses. Well, buprenorphine isn't just a partial mu-opioid agonist. It hits a couple different receptors, and those other actions has been shown to reduce the hyperalgesia that is associated with opioids. So it prevents negative reinforcement loops. It improves the effective anesthesia. It helps with some alternate pain receptors in your body. It helps with that intense emotional response that you get when you use chronic opioids. That's like really well documented, that like those people that freak out at the littlest thing, like that's the opioids talking. And bupe can have some reduction of those things, even if you're using it in conjunction with other opioids. So if you're using bupe as a backbone with PRN, full agonist opioids on top of it, you're still significantly reducing their risk, and you're blocking a lot of that anti-hyperalgesia. So why is bupe a better opioid? I think the clear message is that full opioid agonists, they work in your whole body about equally. They're absorbed into your brain. They suppress euphoria. They cause euphoria, but they also cause respiratory depression. Buprenorphine really doesn't cross into your brain that much. It helps with some cravings, but it is really highly active for pain below the blood-brain barrier. Now this is interesting. Some patients will tell us that, you know, bupe doesn't really treat my pain. And when they tell you that, I think what they're really saying is bupe doesn't really get me high like oxycodone does. It doesn't give me that rush or that central feeling, because a lot of the patients that we're treating with oxycodone have central pain. They don't have back pain anymore. They have like a neuroplastic changes because, or they have terrible lives and they're using oxycodone as like a coping mechanism. Bupe does a great job of treating their true peripheral pain. All right, so the meat of this talk, the new information, I guess, for those of you that are doing this work already, is how do we start patients on bupe? The answer, I'm sure you know by now, is it's complicated. It's difficult to get people on this medication. There's some steps that I can help bring you through, and this is changing. The most important thing to know is there's this thing called precipitated withdrawal, right? Which classically is if someone has full agonist opioids and you give them buprenorphine, if they have a lot of full agonist opioids on board, because the opioid receptors have a high affinity for that buprenorphine, which is a partial agonist, it basically is like slamming the brakes. It rapidly goes from 100% receptor activity to maybe 60% receptor activity, and causes all of the bad stuff associated with opioid detox. Now, so a lot of people, even with chronic pain patients, anyone, when you start to talk to them about buprenorphine, they're like, I hate that stuff. It makes me super sick. I'm never going to take it again. So I think we just need to be more comfortable telling our patients, well, you did it wrong whenever you took it. I can help you get on this medication safely, and it won't make you sick if you follow these instructions. And it's a really potent pain drug. It can help save your life and treat your opioid dependence. It's a safe opioid. This is something that we should use more. So one of the reasons why we need to change the way we do bupe induction is fentanyl. Like I said before, it is basically, if you look at studies where they're doing drug testing of opioids, it's in like something like 90% of samples of drugs. Like that's where they go buy some drugs from the street and then like see how much fentanyl is in it. It's in almost all of it. Well, fentanyl is different than heroin in that it's a fat-soluble drug, and chronically using fentanyl gets into your body. The clearance rates, it takes on average around 2 weeks for fentanyl to leave your body, and some people on lower uses about 4 days, some people with higher uses up to like closer to a month. So this makes a lot of the opioid crisis a little bit more difficult, because now people have this protracted withdrawal syndrome, right? Because instead of the drug having a really intense withdrawal and the drug leaving them over like 2 days, they have withdrawal, pretty severe withdrawal for 2 weeks off fentanyl. Also, if you give them buprenorphine, you run the risk, since they do have fentanyl and fentanyl metabolites in their body, you run the risk of giving them precipitated withdrawal, because this fentanyl is hanging around for longer and longer. Another kind of emerging fact that's really important to know about bupe is that the way when we were using heroin and we were inducing people on buprenorphine, what we tended to do is give a middle dose. We were giving people 2 or 4 or 8 milligrams of Suboxone or buprenorphine products when they were in some level of withdrawal. Well, what you need to know is that bupe at those middle doses seems to have more of a blockade effect. It's not the naloxone working, it's the bupe itself. It works like Narcan, it works like naloxone, and it causes a blocking effect. So giving those 2 or 4 or 8 milligram doses to patients who have fentanyl in their system is a really bad idea, because it greatly increases the risk for precipitated withdrawal. There are 2 ways around this. One is you do really low dose bupe. You start, and I have a protocol I'll share with you in just a few slides, but you start with 1/2 of a milligram of buprenorphine and you slowly titrate up. And if you do that, you're not really blocking or having an agonist. The effects are about equal. So you're insidiously increasing the bupe and you're not making them sick. Or high dose induction, which is something that's gaining popularity in the fentanyl era. That's where at high doses, bupe actually has more of an agonist effect. So if you hit them really hard, you get past that blockade, and you can overcome the precipitated withdrawal that you're going to get with fentanyl. So this is, I think, one of the most important slides I got from the ASAM conference, and it's kind of busy, so I'll explain it in just a second. There's 2 different induction methods: low dose, which is formerly called microdosing, and high dose, which is formerly called macro induction. The addiction experts really hate the term microinduction or macroinduction, because it's implying like microinduction implies, like, it sounds like microdosing, which is like non-therapeutic dosing, which is not true. It is therapeutic dosing. So if you look on the left side of this graph, you have bupe dose. And then on the right side is like the actual serum concentration that they get. And then this is like the x-axis here is either if they're in withdrawal or not in withdrawal. And what you can see is if you hit them really hard with really high doses of buprenorphine, you don't get into that blue precipitated withdrawal range, because you get the agonist effects of buprenorphine. Or if you give them tiny doses, 0.25, 0.5, 1 milligram, you also don't get into that precipitated withdrawal range. But anything in between 1, 2, 4, 8 milligrams of bupe gets you in that danger zone. So I have 2 different protocols to share. and the good news is I created some handouts, and Irma is going to send them out to the group to use. There's a patient-facing handout and a physician-facing handout for all of the stuff I'm going to share with you. So low dose induction, how do you actually do it? Well, I see patients once a week in my practice because that's the soonest I can ever actually get them in. So what I do is I prescribe 18 2-milligram films for 1 week. People can mess up cutting them. So if you give them 21 films or a little bit more, totally fine. The way low dose induction works is you have them cut into quarters, and they take a quarter of a 2-milligram film on day 1, a quarter of a 2-milligram film BID on day 2, half of a 2-milligram film on day 3, a full 2-milligram film on day 4, 2 twos in the morning and 2 twos in the evening, day 5, and then you do 2, 2, and 2, and 4, 4, and 4, and then they're back in your clinic on day 7. The thing about low dose induction that is important to point out is that you can't stop using opioids right away with this approach. So you actually have to instruct them to keep using as they gradually increase their opioid dose. This is something that freaks people out. Many people don't feel comfortable with this, but they've been using opioids for a really long time. It is okay to tell them that during this week, you can use on top of your buprenorphine. It's not going to make you sick. Just use however low amount that you need to not get sick. Try not to use to excess. They do not need to be on a certain morphine male equivalent to do this. You can do this on really high doses of opioids. For pain patients, Crystal, I think this is a perfect approach because many patients with chronic or even acute pain, you can't really get them. It's kind of cruel to get them off of their chronic opioid to do a high dose induction. So slowly going up on the bup dose is a much better approach. There's another way to do this. So I don't know about you, but cutting films and taking them multiple times a day, some of my patients just don't have that higher cognitive function to be able to successfully do this, to be honest. And I've seen a bunch of people mess this up when I've tried to tell them to do it as an outpatient. So there is a low dose patch method, which I think is pretty cool to talk about. So Butrans patches, if you don't know, it's a buprenorphine patch that does 10 micrograms an hour, which is a relatively low dose. It's actually roughly equivalent to like 2 milligrams of Suboxone if you look at the pharmacology after 48 hours. Patches are indicated for the treatment of pain, not for addiction. But really, honestly, many of our patients with opioid use disorder have some level of chronic pain. So I think it's fine to use it this way. So I've found the patch method really helpful for some of our patients. So on day 1, you put a 10 microgram patch on and you're continuing all of your opioids. Day 2, you just keep taking the same opioids. Day 3, you put a second patch on, you keep the old one on. Day 4, you have your patches on, and day 5, you can take half of an 8 milligram buprenorphine film in the morning and in the evening. And then day 6, you can take the patches off, take a full 8 milligram film in the morning and evening. Many of us treat Medicaid patients. One of the great things is that Butrans patches is available via Wisconsin Medicaid, so it's readily available to our patients. One of the not so great things is pharmacies don't always stock this drug. So if you're going to do the patch method, just normalize that your patient might have to wait for the patch to come in, or like call ahead or tell your pharmacy or figure out which pharmacy actually has these patches. And then here's the high dose induction method. So the critical thing for high dose induction, as you need to know, is you have to be in withdrawal. If you're not in withdrawal, then don't do it. Do the low dose induction. So what you have to be at least 12 hours from your last use, but ideally you wait even longer, like 24 to 36 hours from your last use of any drug. Because of the long half-life of methadone, don't do high dose induction for methadone. Do the low dose approach. It works the low dose approach works pretty well for methadone. So what you should tell people over and over is like, you don't feel sick, just wait longer. And make sure they know what withdrawal is. So they have to have 5 of those symptoms that you see on the right side of the screen. So the high dose induction method is pretty simple. When you're in withdrawal, take 2 8-milligram films, put them on your tongue, wait 10 minutes. If you feel better, you're done. If you still feel sick, take another 8-milligram film, wait 10 minutes. If you still feel sick, take another 8-milligram film. People are gonna be like, wait, wow, that's a lot more than I'm comfortable giving or that I've given in the past. This is safe. Bupe has a ceiling and respiratory suppression. There are hospital-based addiction doctors that have given up to 128 milligrams of Bupe, like repeatedly to patients. And there's no significant side effects or respiratory suppression or major issues. So you can give people 32 milligrams in the first day. It's also important to normalize that people are going to have at least mild withdrawal during this syndrome, during this induction. So you're going to want to prescribe comfort meds along with it. Yeah, Crystal, thank you for bringing up the switch from methadone to Bupe. No, it does not matter. You can have somebody on the highest study that they talked about in the ASAM conference a couple weeks ago was they had a patient on 150 milligrams of methadone that did this method and did fine. They just continued their methadone until day 6 and then stopped. So just some general tips about induction. Remember that people are going to have subacute withdrawal during Bupe induction. That's normal. So what you should do is when you're prescribing buprenorphine, ask them what their typical withdrawal syndrome is. And everybody's a little different here. And then just prescribe them the comfort med that makes sense for them and tell them how to use it. Another best practice is to check in. If you can have your nurses call, or it's great if you can do interval check-ins between the week, but at least see them in 1 week when you do this method. From experience, I'll tell you that people will mess this up and they'll freak out and they'll call the clinic. So make sure that you kind of talk your nurses through, if someone is in precipitated withdrawal, what should you do? And the answer is really simple. Just take more Bupe. If you take 2 milligrams of Suboxone instead of 1/4 of a milligram, like we were telling you in the instructions on your microinduction, then just take a whole bunch of the 2s. You can take, I don't know, 4 of them. Wait 10 minutes. You still feel sick, take more. Take some communication skills though. Like, here's this medicine that's giving you a panic attack, making you vomit and have diarrhea. Take more of it. But it works. So just have them take more Bupe if they have precipitated withdrawal. Don't wait to find the doctor in the clinic and just take more Bupe. It's safe. People are going to keep using drugs. This is not a miracle cure. So just normalize that it's a process, and gradually the behavior gets better over time. But, in the first few months, occasional use on top of the buprenorphine is totally normal. And it's just something that you can work towards eliminating over time with motivational interviewing and increased dosing. Of course, people do this wrong all the time. So I just have to have this slide that Bupe goes under the tongue and you shouldn't swallow that spit. Don't talk, don't eat, don't smoke. I have a lot of patients that swallow it. and it just doesn't work that way. So don't swallow it. I think I have 2 more slides. Maintenance dosing. So this was, I think, a pretty powerful slide that I got from this addiction conference. That I think we are probably underdosing a lot of our patients on buprenorphine. Our goal is the blue stuff on the right. You want to block respiratory depression. One of the nice things about using bupe with people that are also using chronic opioid agonists is it has some competitive inhibition of the respiratory suppression of those other chronic opioid agonists. All right, so if you have bupe, if you're using fentanyl oxycodone, it has less of an effect on you, so you're less likely to overdose and die. But you need to have relatively high levels of bupe in your body in order for that to successfully work. So you need 16 to 24 milligrams a day to really significantly block that respiratory suppression. So we have patients on like 4 once a day or 4 twice a day. Those are kind of homeopathic doses, and then they're not really meeting where we want. You also want to block opioid craving and seeking behavior. You need higher doses for that. But what we often do is, if you're just titrating to not having cravings, then you might be underdosing it, because you can not have cravings, but still not be fully protected by using higher levels of buprenorphine. Don't forget about primary care. So at Columbia St. Mary's, sometimes our residents will complain and they'll say, Dr. Hayes, we have just so much MAT. It's crowding out our care. And I hate that complaint, because we just have a lot of patients, and all of these patients have primary care needs. So once you get them stabilized in addiction, stop talking about the buprenorphine and start doing all of the awesome stuff that we do that reduces mortality and helps people live better lives, right? I have a lot of patients with opioid use disorder that I'm just doing the regular primary care doctor stuff and prescribing them buprenorphine at the end of the visit. So stigma is another thing as educators that we really need to watch out for. If we have a colleague that is calling someone a substance abuser, you should correct them and say, the correct term is a substance use disorder. It's like someone saying something racist. It's a microaggression, and it's stigmatizing language, and you should stop them from saying it. If you find a resident or student or colleague saying negative things to a patient, or even in the call room about patients with substance use disorder, you should stop them. It affects their care. Shaming a patient does nothing more than increase their use of drugs, and increases the harm associated with drugs. So watch your language with treating these patients. And the other important thing to really think about in many of our practices is, I talked a lot about sublingual buprenorphine, but getting people on to the injectable buprenorphine drug, Sublocade, is a pretty effective treatment for opioid use disorder. I will say there is no real evidence that Sublocade is effective for the treatment of chronic pain. And I think I asked a pharma rep about it at ASAM, and they were saying that it's because it's released so slowly that it might not have as a potent pain effect as we think. But why Sublocade is more effective is when you're taking sublingual bupe. These are, by the way, pharma slides, so take them with a grain of salt, but they're good graphs. When in the green here, you have the serum concentrations of someone taking sublingual bupe, and you see that they are swinging up and down. Their levels are going high and low below the threshold, which is 2 milligrams of serum concentration that has been shown to actually block cravings and create that protection against opioid overdose. When you get people stabilized on Sublocade, their bupe levels are consistently quite high. So you get them into that that area above 2 where they're really safe and they can use other opioids and they don't have any cravings. It's a really long-lasting drug. What you do with Sublocade, it's a whole nother talk, but you give them 300 milligrams for 2 months, and then the protocol says you can go to 100 milligrams after that, and then you keep their levels quite high. For high dose users that are using fentanyl adulterated drugs, we often keep them on the 300 dose. Another misconception about Sublocade is if you're using it, you should dose them with PRN buprenorphine on top, because there's like a basal bolus strategy that seems to help people. It doesn't increase the risk for euphoria or addiction or overdose. So give them sublingual bupe to take on top of the Sublocade. Because what tends to happen is, particularly on like a couple days into the shot, your levels fall a little bit, and the sublingual supplementation can really help. All right, my last slide is Sublocade tapering. So you have a patient on chronic opioids and they want to taper. This could be heroin. This could be buprenorphine. Or this could be like oxycodone and someone's really motivated to taper. Well, a really novel strategy that's pretty well supported by the literature would be that chronic opioid patient. What you could do is do either a patch or a low dose induction to get them buprenorphine in their body, get Sublocade in their system, give them at least 2 shots. And then if you look at this graph, they'll have, once you stop buprenorphine, they can have the medicine in their body for like up to 4 months, depending on how high your dose was. So this kind of makes tapering quite easy. It eliminates all of like the subacute withdrawal syndrome that you get from tapering. So having Sublocade on board and helping them taper. Or this is the method that I really like now when patients are they're on bupe for a long period of time and they say, Dr. Hayes, I want to stop taking my Suboxone. I feel like my life has changed. I do a safety assessment, like, is their life actually changed? Would they actually benefit from a taper? And if we both think the answer is yes, then I offer the Sublocade taper, which is where I give you at least 2 shots. You just stop taking the bupe after that. And because the drug naturally leaves your system, I'll just give you some PRN Suboxone that you probably won't need. And you can just stop using all opioids altogether. And the studies about people that taper off Sublocade are really robust. It's really people that have done Sublocade at least 4 shots. In the Recover study showed that like 80% of them at 1 year after tapering off the drug altogether were no longer using opioids. So that's pretty powerful data that this is an effective strategy. All right, I wanted to leave some room for questions. So that's all I really have. If anyone has any questions about any of the stuff I just covered, I'd be happy to go into more in depth about it. I also want to normalize that, like, you can email me and I would love to share this information. I've helped a lot of people get comfortable and start to prescribe buprenorphine. Irma is going to be sending out after today's talk 4 different handouts. One is a protocol for those low and high dose induction. And then 3 of them are a patch-based induction handout for patients, a low dose sublingual induction method for patients, and a high dose handout for patients. And you can use that. They're in Word, so on purpose. So you can edit them as you see fit. I also want to emphasize this whole thing isn't just me being crazy. ASAM is actually going to put out a practice guideline in the next 4 months about how to do low and high dose induction. The people that wrote that paper were teaching the courses I went to. So I just figured we should know about it ahead of time, and you know, maybe we can prevent a couple overdose deaths if we start doing this sooner rather than waiting until the literature percolates through us. So I guess, is there any questions about the stuff that I shared?
Hey, John, thanks for bringing this to us. This is really, really interesting, and I think helps get us out of the perspective that patients are just gonna have to suffer to start buprenorphine, which I think is a way that a lot of us have learned how to start people.
Yeah.
I guess I had a question about some of the initiation protocols, like the low dose, high dose, or kind of middle dose, which had been what we had been doing more before. Do you have a sense for how you would select which of those to use for different patients? I guess I'm thinking of a patient who's definitely using fentanyl, a patient who is being prescribed opioids like full agonists that probably has an opioid use disorder and is transitioning in particular.
Yeah, it's a great question. One is tolerance for withdrawal. Like, I've asked a few people in the last couple of weeks, like, hey, your one option is you would have to be in withdrawal, and then take a higher dose of buprenorphine, do the high dose induction. The other method is you would continue to use and slowly increase the amount of buprenorphine in your body. So those people that I know are really intolerant of any withdrawal syndrome, are really fearful of withdrawal, they're the ones that do the low dose induction for. People that have chronic opioids and there's just no way they're going to stop taking the chronic opioids, or people on methadone, those are the ones that low dose induction is really appropriate for. For people that come into our addiction clinics and they say, you know, I'm motivated, today's the day, I'm already in withdrawal, I want to stop using, then high dose induction is a really great strategy for them. The people that are motivated and they think they can actually stop. And that's like, you know, a lot of patients that we see, they naturally go through starts and stops, right? They'll have periods where they're like, oh, I'm gonna kick heroin, and they'll stop for as long as they can, and usually they end up using within 24, 36 hours. So those people would be good for high dose induction. Does that answer your question, Brian?
Yes, thank you.
John, can you speak at all about the, you mentioned needle services that deliver across the US. Can you elaborate on that a little bit?
I probably just need to send an email, but there are a few different needle exchange places that are mail-based. Like in Milwaukee, we have a really fantastic, we have LifePoint Needle Exchange that will like literally drive to your house and give you hookers and needles and test strips. But you know, I don't know if Green Bay has that resource, but I'll share it with you, Crystal, that like there was a few, that there was like a harm reduction talk at ASAM where they listed a few of them. But it's just like you sign up and then they send you stuff. I got a question through the chat, like older patients on fentanyl, like low dose fentanyl, for example, for chronic pain. Those would be, I think, excellent candidates to switch to buprenorphine safely using a patch-based method. Like if you think that, I don't know, not all people have cognitive impairment, but this is just busy. So if I had somebody on like a fentanyl patch, you could totally cross taper using the buprenorphine patch-based method and successfully get them onto a much safer and highly effective analgesic wise, opioid. Or you can simply just, for people on low dose fentanyl, I don't know why you would give low dose fentanyl for chronic pain. It's a terrible strategy. You can just use Butrans patches themselves. Get someone up to a 20 microgram Butrans patch for like that old person with tons of back pain and arthritis, and that's also a really effective strategy. Other questions? Okay, everybody. Well, I'll give you some time back. Thanks a lot for tuning in super early in the morning to learn more about caring for people with opioid use disorder. I think your patients will be better off for it. I'm happy to help you through it, and watch your email for some protocols that I wrote to kind of help you through all of this.
Thanks, John.
You're welcome.
Thank you so much, John.